So, hey friends, today we are going to revise Physiology of Pain, and this is from MedNotes. Okay, so you can download this app in your phone and take your notes and videos from there. So, Physiology of Pain. Pain is defined as one minute, unpleasant and emotional experience associated with or without actual tissue damage. Pain. Acute is divided into two parts, acute and chronic pain. Acute pain is short, sharp, within a small area, and chronic pain is constant with different intensities and lasts longer. Okay, so pain is an important protective, unpleasant sensation with survival benefits. Important protective, unpleasant sensation with survival benefits. Pain sensation has two components, fast pain and slow pain. Fast pain. First sensation, bright, sharp, and localized, carried by AS type nerve, A delta type nerve fibers, and slow pain, dull, diffused, and unpleasant, and carried by C fibers because, as we know, that they are non-myelinated. So, okay, and this one is myelinated, so it is fast pain, myelinated. Pathways of pain sensation from skin to the deeper structure, from skin and deeper structure, from face carried by trigeminal nerve, face trigeminal nerve. 1 minute. From face it is carried by trigeminal nerve, from viscera by the thoracolumbar, vagus and glossopharyngeal, from pelvic region sacral parasympathetic nerves. From skin and deeper structures, receptor of pain are free nerve endings which are distributed throughout the body. First order neurons. These are cells in posterior nerve root ganglion which receives the impulses of pain sensation from pain receptors to spinal cord. Fast pain sensation A delta A delta fibers fast pain sensation synapses with neurons of marginal nucleus in posterior gray horn. Slow pain sensation by C type synapses with substantia gelatinosa of Ronaldo in posterior gray horn. Okay. Second order neurons. Neurons of marginal nucleus and substantia gelatinosa of Rolando forms the second order neurons. Fast pain fibers Fast pain fibers, second order, originate from marginal nucleus and terminate in ventroposterolateral nucleus of the thalamus. Slow pain fibers, second order, originate from substantia gelatinosa and terminate in ventral posterolateral nucleus of thalamus. And in this diagram, as you can see, these are which are called the marginal zones, substantia gelatinosa and the marginal zone, nucleus proprius, dorsal nucleus, and in an intermediolateral nucleus, motor nucleus of the anterior horn, central canal. And here you can see the areas are divided like this is 1, 2, 3, 4, 5, 6, 7, 8, and 9, and this 10 is comes in the and called the central canal. Okay. Nuclei of reticular betectum midbrain, gray matter around aqueduct of Sylvius, third order neuron. They are neurons in third order neurons. They are in thalamic nucleus reticular formation as in medulla and tectum, gray matter around aqueduct of Sylvius. Center for pain sensation, post central gyrus of parietal cortex. postcentral gyrus of parietal cortex, center for pain sensation. Visceral pain. Visceral pain are referred pain. Visceral pain, pain from viscera, is unpleasant and poorly localized. Causes include ischemia, chemical stimuli like gastric juice, ulcer, etc., spasm, and overdistension. And here we will talk about referred pain. Okay, referred pain. It is pain that is perceived at the site adjacent to or away from the site of origin. Like as you know that gallbladder pain refer to the right shoulder. Okay, deep pain and visceral pain are referred to other area, not superficial pain. Examples. Examples of the referred pain are cardiac pain is felt in left arm and shoulder. Pain in ovary at umbilicus. Pain in testis is felt in abdomen. Pain in diaphragm is felt at shoulder, and pain in gallbladder is epigastric region. If renal pain is referred to groin. According to dermatomal rule, the reason mechanism of referred pain is referred to a structure which is developed from same dermatome from which the pain producing structure is developed. So here you can see is developed from the same dermatome from which the pain producing structure is developed. So thymus, here you can see liver and gallbladder, appendix, ureter, urinary bladder, kidney, urinary bladder, colon, ovary, small intestine, pancreas, stomach, heart, spleen, and lung and diaphragm. So what you are watching right now, like I can say that the heart pain is referred in this area like this, from chest to the medial side of your forearm and arm. Okay, so this picture is of very important. Neurotransmitters involved. Okay, neurotransmitters involved glutamate and substance P are the neurotransmitters secreted by pain nerve fiber. A delta fiber uses glutamate and C types of fiber uses substance P. Noxious stimuli, peripheral nociceptors, nociceptors for pain, as you know, dorsal horn, like primary afferents A delta K mu, and glutamate is released. Presynaptic effect decreases calcium influx, decreases transmitter release. Postsynaptic effects increases K plus conductance, increases hyperpolarization. Postsyn- Postsynaptic receptors mediating pain transmission in the dorsal horn. NK1, AMPAR, NMDAR. Analgesia system. Analgesia systems means the pain control, like we take analgesics to reduce the pain. Okay, pain control system. It is also called endogenous analgesic system. Analgesia system has got its own pathway through which blocks the synaptic transmission of pain sensation in spinal cord and thus reduces the pain. Analgesic drugs such as opioids act through this system and provide relief. Like here you can see nociceptors. When glutamate is released, glutamate, neuropeptides, enkephalin, spinothalamic tract neuron, sensory input control. Opioid exposure, opioid control, opioid. 1 minute. Enkephalin and opioid. No input opioid enkephalin, sensory input plus opioid control enkephalin. Sensory pain pathway, lateral spinothalamic tract, marginal 1 minute. Sensory cortex, analgesic pathway, periaqueductal gray matter nucleus, raphe magnus, inhibition of pain transmission, posterior nerve root ganglion, spinal cord 1 minute, spinal cord, medulla, midbrain, thalamus, and in here you can see like reticular formation, and here is the sensory cortex. Analgesic pathway is it. Okay, so how we have to go, like this. So start like this, and Rupali. Okay, applied analgesia, loss of pain sensation. Analgesia is loss of pain sensation. Hyperalgesia, increased sensitivity to pain sensation. Types: primary, secondary hyperalgesia. Primary algesia develops 30 to 60 minutes after injury, lasts for several hours or day. In the area of redness, no painful stimuli as touch becomes painful. Mechanism: decreased pain threshold due to local axon reflex releasing substance P. Secondary hyperalgesia developed later, shorter duration than 1 RY. In healthy skin surrounding red area, pain is felt more severe than normal. Central sensitization explained by convergence facilitation theory. Paralgesia, abnormal pain sensation. Paralgesia is abnormal pain sensation. Phantom limb pain. In 1551, Ambrose Parra, a military surgeon, wrote the patients long after the amputation is made so that they still feel pain in the amputated part. Of this, the complain strongly, a thing worthy of wonder and almost incredible to people who have no experienced this pain. This is perhaps the earliest description of phantom limb pain. Phantom limb pain. Between 50% and 80% of amputees experience phantom sensations, usually pain in the region of their amputated limb. Phantom sensation may also occur after the removal of body parts other than the limbs. For example, after amputation of the breast, extraction of a tooth, phantom tooth pain, removal of an eye, phantom eye syndrome. Numerous theories have been evoked to explain this phenomena. The current theory is based on evidence that the brain can recognize if sensory input is cut off. The ventral posterior thalamic nucleus is one example where this change can occur. In patients who had their leg amputated, single neuron recording shows that the thalamic region that over received input from the leg and foot now respond to stimulation of the stump thigh. Others have demonstrated rib mapping of the somatosensory cortex. For example, in some individuals who have had an arm amputated, stroking different parts of the face can lead to the feeling of being touched in the area of the missing limb. Therapeutic highlights: the use of epidural anesthesia during the amputation surgery may prevent the acute pain associated with the surgery, thereby reducing the need for opioid therapy in the immediate postoperative period. This anesthetic procedure resulted in reduced incidence of phantom pain. Spinal cord stimulation has been shown to be an effective therapy for phantom pain. Electric current is passed through an electrode that is placed next to the spinal cord to stimulate spinal pathways. This interferes with the impulses ascending to the brain and lessens the pain felt in the phantom limb. Instead, amputees feel a tingling sensation in the phantom limb. And that is all about this chapter, Physiology of Pain. And this is a very important questions for our professional exams. Okay, so all the best. Goodbye.